Welcome to the second training video for the Coral Study. I'm Rachel Johnson, Associate Professor in Primary Care at the University of Bristol, co-lead and Clinical Chief Investigator of the Coral Study. This video is for GPs or clinicians, which may include research nurses, ANPs or clinical pharmacists, who will be helping to run database searches and screening to identify potential participants. I'm going to talk through the processes of database searches and screening patients based on the eligibility criteria for Coral. As a quick reminder, this is the research question that we are addressing with the Coral study. In patients with heart failure with reduced ejection fraction, is the addition of coenzyme Q10 or CoQ10 to usual care clinically and cost effective? Please note that as we go through these slides, we are using the term left ventricular systolic dysfunction, abbreviated to LVSD, to mean reduced ejection fraction. And people with heart failure with left ventricular systolic dysfunction, or LVSD, are the population eligible for Coral. This slide summarises the first tasks in the recruitment of the GP practice. These were covered in the study introduction video. In this presentation, I will cover the steps highlighted here within the green box. This is an overview of the steps required for the database searches. There are 4 steps. Each step includes data to be extracted from EMIS or System 1 and an action to be completed. In Step 1 and Step 3, the action is simply to send anonymous data to the study team, while in Steps 2 and 4 there are additional actions. Most of the steps can be done by anyone delegated to do so on the Coral delegation log. However, importantly, the eligibility screening in Step 4 must be completed by a GP, who is also delegated to do so on the delegation log. Steps 1 and 3 are essentially the same. Each of these steps run a search for patients at your practice aged 18 or over with heart failure and produces an anonymous report including their heart failure code and demographic information, specifically their ethnicity, age, gender and measure of deprivation. In both steps 1 and 3, we are asking you to send these data to the Coral study team. Steps 1 and 3 will help us to understand the baseline demographic information of the practice's heart failure population before and after Step 2, which I will come to shortly. A key aim of Coral is to recruit a diverse and inclusive population of people with heart failure, and these searches will help us to understand how well we are doing this. Step 2 is to run a search which identifies patients in your practice who are over 18 with heart failure but do not have coded left ventricular systolic dysfunction or LVSD. Study exclusions such as warfarin prescription, soy or peanut allergy and coded lack of capacity to consent are applied in this search. Step 2 produces a list of patients who may need a review of their medical records to see if they have evidence of LVSD and should be coded with LVSD. The action for this step is to screen this list and to add the QOF code for LVSD to a patient's medical record if evidence of LVSD is found. As I said previously, Step 3 is the same as Step 1 and produces anonymous data to send to the Coral team. We will compare the data from Step 3 with Step 1 to see if there are socio-demographic differences in patients who do or do not have LVSD coded. Steps 2 and 3 are optional for you as a site. If you have capacity to check your LVSD coding in your practice, then we would like you to do so. It will help us running the study as potentially more people will be invited to take part, but it will also help you in terms of QOF points and coding accuracy. However, we do appreciate that you may not have capacity to do this in your practice. Please confirm with the Coral study team if you would prefer not to do these steps. Step 4 is to run the eligibility search. This identifies patients who are over 18 years of age with coded heart failure and coded LVSD, study exclusions are applied as before. There are two sets of data produced in step 4. First, we need to know the number of patients who were removed based on the 3 exclusion criteria that we have searched for. This is data that we need to show the flow of patients through the study. The second set of data is a list of patients who need to be screened for eligibility. The action for this step is to screen this list based on inclusion and exclusion criteria provided by the Coral study team. This step must be completed by a GP who is delegated to do this on the Coral delegation log. At the end of these steps, we will ask you to send us the data from steps 1, 3, and 4. As described on the previous slide, the aim of step 1 is to report socio-demographic characteristics of your heart failure population before the list is screened for evidence of LVSD. The data from this step will contain a heart failure code, ethnicity, age, sex, and measure of deprivation. This will be an anonymous report, so no consent is required from your patients. These data will be compared with the data from step 3 if the LVSD coding step has been completed. So we will ask you to run the search, save the search output, and at the end of the process, send the data to us. The aim of step 2 is to find people with LVSD, or left ventricular systolic dysfunction, who are not currently coded as having LVSD, and to add an appropriate QOF code for LVSD to their records. As a reminder, to be eligible for the Coral study, patients must have evidence in their GP record of coded heart failure and left ventricular systolic dysfunction, or LVSD. The data from this step identifies people on the heart failure list who do not have LVSD coded. The report excludes those taking warfarin, people with soy and peanut allergy, those with coded lack of capacity to consent, as these people would be excluded from the study. The action in this step is to review the medical notes of these patients and add QOF codes for LVSD if evidence for LVSD is found. I will talk more about this process in the coming slides. Importantly, this step is optional. We would like you to complete it if possible, as it helps you with QOF and potentially invites more patients to the study, but we do recognise that it may not be feasible. If you as a site do not have capacity to complete this coding stage, please contact the Coral study team to discuss.
So why are we doing this? We know that heart failure coding is not always accurate in medical records, and that people with LVSD do not always have the correct coding. Practices should expect at least 50% of their heart failure population to have coded LVSD, although this isn't always the case. Coding for LVSD is important because it allows evidence-based therapy to be offered. There are many more evidence-based therapies available for heart failure with LVSD than for other forms of heart failure. Therefore, to ensure that the trial is inclusive and that everyone who has the potential to benefit is invited, it is important to do this step and code LVSD where there is evidence.
To keep things straightforward and consistent with QOF, we are using the QOF codes for heart failure and for LVSD. There are 2 heart failure registers for the purposes of QOF. The first, QOF Register 1, includes all people with heart failure coded. The second, QOF Register 2, is a subset of Register 1 and includes all those with heart failure with evidence of LVSD. And this is the population that we are interested in for this study. To be included in Register 2, people need to have a code for heart failure and an additional code for LVSD. There is a list of approved codes for LVSD in QOF. These include codes for left ventricular systolic dysfunction and also for reduced ejection fraction, both of which are consistent with LVSD. In a later slide, we suggest specific LVSD codes to be used for step 2 of the database searches.
This slide shows the process for adding LVSD coding to patients identified from step 2. This stage does not have to be done by a GP, but can be done by another appropriately trained clinician who has been delegated to do so on the CORAL delegation log. As a reminder, CORAL Step 2 will identify any patients aged 18 or over with heart failure but without LVSD coded in their medical records. The task is to review the medical records for evidence of LVSD. Evidence of LVSD might be found, for example, in the reports of echocardiograms or in the results of letters from specialist services, including community heart failure clinics. Patients may have had more than one echocardiogram or coded ejection fraction, and the results may change over time. It is possible that people can be diagnosed with heart failure with LVSD at one stage, but subsequently their systolic function improves. Please note that if patients have ever had a diagnosis of heart failure with LVSD and still have current heart failure, i.e. they are still on the QOF heart failure list, they are potentially eligible for inclusion in the study, even if a current or recent echo shows heart failure with a normal ejection fraction. Please use your clinical judgment as you know your patients better than we do.
If you find evidence of LVSD when looking at the medical records, you should add a QOF code for LVSD to that patient's record. If you do not find evidence of LVSD, no further action is needed. For CORAL, we are defining evidence of LVSD as written description of left ventricular systolic dysfunction or an ejection fraction of less than 50%. Although worded slightly differently, this includes the same population of people with heart failure due to LVSD used for QOF Register 2. If you find evidence of LVSD, you should add the QOF code for LVSD to that patient's record. Please use one of the specified codes listed here with their accompanying SNOMED codes. If you do not find evidence of LVSD, no further action is needed. The process for adding codes to medical records is described in the CORAL EMIS or System 1 instructions. This slide gives further detail about how to identify heart failure with LVSD by looking at imaging reports such as echocardiograms or clinical letters, for example from cardiology services. As we have said, people with heart failure with LVSD are potentially eligible for CORAL. Heart failure with LVSD may also be described as heart failure with mildly, moderately or severely reduced or impaired LV systolic function. It may also be described as heart failure with reduced LV ejection fraction, which is usually understood to mean an ejection fraction of less than 40%, or heart failure with mid-range or mildly reduced ejection fraction, which is an ejection fraction of 40 to 49%. All of these can be coded as having left ventricular systolic dysfunction using the codes in the previous slide. People with normal left ventricular systolic function are not eligible. This may also be called heart failure with normal or preserved ejection fraction, or diastolic heart failure, or heart failure with ejection fraction of 50% and above. It's important to note that people with heart failure with left ventricular systolic dysfunction can also have abnormal diastolic dysfunction. These people are still potentially eligible.
If you have completed Step 2, please follow this with Step 3. The aim of Step 3 is to report socio-demographic characteristics of your heart failure population after the list is screened for evidence of LVSD, if you have done this step. The anonymous data from this step will be compared with the corresponding data from Step 1, so we can assess whether there are differences between those who do and do not have LVSD coding, for example in terms of their age or deprivation.
Next is Step 4. The aim of Step 4 is to identify potentially eligible participants for the CORAL study. Running this step produces two sets of data we need. The first is a list of how many of your patients have been removed based on exclusion criteria. People will be excluded if they have a warfarin prescription, coded peanut or soy allergy, or coded lack of capacity to consent. This is data that we need to show the flow of patients through the study. The second part of this search will identify people 18 and over with heart failure and coded LVSD after the study exclusions mentioned have been applied. This list may include new patients with LVSD that you identified in step 2. Those identified through this part of the search can move to eligibility screening, which I will cover in the next few slides. Eligibility screening is a GP task. Patients identified for eligibility screening will be screened using a CSV file. We will send you a CSV file with pre-populated study identifiers. A GP is required to add a numerical code to explain why each patient is eligible or ineligible based on study exclusion criteria. Please make sure you are using the most up-to-date version of this screening log as found on the Coral Study website or sent by email by the Coral Study team. We will send you step-by-step instructions on how to export these data into a CSV file and into the correct format for screening. This will be in the Coral EMIS or System 1 instruction document. As just described, you will need to add a numerical code to each patient to identify whether they are eligible to take part in the study or not. These are the eligibility codes we will be asking you to add. Code 1 means the participant is eligible, while codes 2 onwards are different ineligibility codes. The list produced in step 4 should only include people who are over 18 with a code for heart failure and a code for LVSD. Therefore, we do not expect any patients with codes 2 to 5 to make it to this stage, as they should have been filtered out during the EMIS or System 1 searches. Codes to check for in particular at this stage are the ones highlighted in red here: current warfarin use, soy or peanut allergy, currently involved in another clinical trial, and lack of capacity to consent. And to note about code 9, lack of capacity to consent. Participants must be able to give informed consent to take part in Coral. Importantly for Coral, we are trying to be as inclusive as possible. We will ask you to confirm whether the participant has capacity or not, but we ask that you do not exclude potential participants who have mild cognitive impairment. Our primary outcome measure, the KCCQ, has been validated in patients with mild cognitive impairment. We have not excluded people with dementia, as some people in early stages of dementia may still have capacity to consent to take part. Please also do not exclude people because of language barriers. We are translating documents and have provisions to use a translator's service. You can use the eligibility code 99 if you think there are other reasons why we shouldn't contact a patient, but we ask you to be as inclusive as possible at this stage. We will also confirm eligibility with patients in a screening call after they have expressed an interest to us, so we will have an opportunity to check these criteria and some additional criteria with the patient. You do not have to make contact with the patient to check any of these eligibility criteria, but please check from your medical records. This is an example of what the eligibility spreadsheet will look like. We will ask you as a GP to check each patient's medical records and add in an eligibility code into the appropriate column highlighted here, and add details into the Specify Ineligible Other column if you select eligibility code 99, Other. In this instance, James Taylor is eligible to take part in the Coral study with the eligibility code 1, but Doogie Howser is not. The clinician has detailed that this patient is currently undergoing chemotherapy and is therefore not appropriate to approach to take part. Finally, Jane Smith has the eligibility code 6, which means she has a current warfarin prescription and is therefore not eligible to take part. The final step in the screening and participant recruitment process is an eligibility reconfirmation. This step must be completed by an appropriately delegated GP at your site. We will ask you to do this after the participant has given their informed consent. This step is to confirm that nothing has changed since the first eligibility check, which may have been a month or so ago, such as a new warfarin prescription or the participant has become pregnant. You will receive automated emails from REDCap, our study database, which will include a link to our survey. As a GP, you are required to confirm that you've checked each of the eligibility criteria against medical records. The email will have the subject line Coral Study, Participant Study ID and GP confirmation of eligibility. We anticipate these will come in over a number of weeks after the invitation pack is sent out via DocMail and after participants have given consent. You therefore need a process to check this regularly. Importantly, for security reasons, this survey will not include any identifiers about the patient, such as name or date of birth. It will only include the Coral Study ID, so you will have to refer back to the screening spreadsheet to link the study ID to patient name. The screenshot on the right shows an example of what the email and survey will look like.
As a reminder, we will ask you to send us a number of files for our records. These will be Steps 1 and 3, which are your anonymous heart failure population demographics before and after your LVSD coding review, if this step has been completed. Both sets of data from Step 4, the first of which helps us know how many of your patients were removed from the eligibility search due to exclusion criteria. The second half is your completed screening log for us to upload to our database.
Thank you very much for watching this training module. The code word for this video is screening. Please add this to your training and delegation log and watch the study introduction video if you've not already done so. If you have any questions about this training or anything else related to the study, you can call or email us using the details here.